Hello, and welcome to another episode of Let's Get It Straight. I'm Katherine West, Infection Control Consultant. Today, our session is going to address filling the gap, how in today's environment we can keep up to date on infection control information that is reliable. Many of you are used to, as well as myself, accessing CDC documents. And many key CDC documents have now been archived and are not accessible. Good long-standing guidelines that we would frequently reference in creating our exposure control plans and our infection control programs. Here's another example. This is the National Institutes of Health sites on the web. There's a notice that says because of a lapse in government funding, the information may not be up to date. Transactions submitted via the website may not be processed, and the agency may not be able to respond to inquiries until appropriations are enacted. Another example of our access to good, reliable scientific information is hampered. So, expert advisory groups that have been long-standing. Many of you have probably heard about HICPAC, the Healthcare Infection Control Advisory Committee. This committee has been in existence for many, many years and is made up of experts for a wide range of disciplines. They are charged with review of data and compiling recommendations that need to be updated or improved, and they send them to the CDC. The CDC then reviews them, and they go out for public comment. Those comments come back, are reviewed by HICPAC, and final recommendations then are submitted to the CDC for acceptance or not. So in November of 2024, HICPAC had been in the process of updating CDC isolation recommendations that had not been updated since 2007. The last meeting of this committee was held in November of 2027 and left a lot of unfinished business because all of the members of this committee were dismissed. So they're gone. So how do these committees work? How do they formulate their guidelines and recommendations? And one of the review methods is called PRISMA. And PRISMA is a method used to summarize, contain tables, and summary of information to help the decision-making process. So if you look at the slide, it says they look at the outcome, they make a summary, how many articles were reviewed, and then grade them on strength, precision, consistency, directness, and confidence in the findings. So here's just an example of what was presented in the November 2024 meeting, and looking at N95 versus surgical masks, a hot topic right now. And pandemic laboratory confirmation on viral respiratory infections. The summary suggested no difference between N95s and surgical masks. And the number of studies reviewed were 10. And down at the bottom, the footnotes give you more places to go for information and further explain the findings. So by each one of these topics, you will see a footnote, and then you would go to that footnote for the explanation. Another example of one of the working charts from that meeting, and I know it's very difficult for you to read, but I will try to give you some of the information. They looked at vital signs when staff were wearing N95 respirators versus surgical masks. They reviewed 4 studies in looking at this topic, and they had serious concerns about the study data and low confidence in the results. And the results had said evidence was inconsistent and inconclusive on N95s and surgical masks dealing with healthcare worker vital signs. They also looked at headaches and difficulty breathing and dizziness. They reviewed 12 studies, and the strength of the studies, they had serious concerns on precision, moderate concerns, consistency, moderate concerns, and directness, no concerns, and a high level of confidence. The summary was the evidence indicates that difficulty breathing, headaches, and dizziness are more frequent among N95 respirator users than surgical mask users. So those are just some of the examples of what the committee does in prep for the meeting, and then all of this is reviewed and discussed and voted on to determine findings. And just one more example, addressing fatigue for healthcare workers when wearing an N95 versus a surgical mask. And they reviewed 3 studies, and you see the results that with regard to fatigue, that was a serious concern. Precision, moderate concern, consistency, no concerns, directness, no concerns, confidence, moderate. That evidence in these 3 studies suggested fatigue was more frequent in N95 respirator users than in surgical mask users. So using evidence, reviewing published studies in the decision-making process, it's good to know how these committees function. So what about the results after the review? HCPAC did not recommend N95 masks be used for all respiratory diseases. And all of the studies, it's important to note, focused on the use in medical facilities. Again, this work was not finalized and the committee was eliminated. The focus of the studies and review on N95s versus surgical masks dealt with medical facilities, not EMS. If you read very carefully, there's no mention of EMS. So let's look at the differences between the two. In a medical facility, staff has many hours of contact with the patient. Shifts can be anywhere from 8 to 12 or more hours. EMS, you have short transport times for the most part. Medical facilities are not able to control airflow in a patient room to any real extent, where in EMS, the rear exhaust fan completely exchanges out the air in the back of your vehicle a minimum of every 2 minutes. And you can put the heating or air conditioning on the non-recirculating cycle. Risk is very low because your vehicle gives you built-in protections. Medical facilities also perform open suctioning. That is breaking open a filtered closed system. EMS does not perform open suctioning. You maintain a closed filtered system. Another important difference. What's going on to help fill the void, to fill the gap? Well, our societies, our organizations are stepping up. The Infectious Disease Society of America is going to pick up work on infection control practices. The Society of Healthcare Epidemiology in America, SHEA, is going to address cleaning and disinfection guidelines for an update. SHEA also just recently published updated HIV post-exposure guidelines for 2015. The last update was in 2013. 2013. Now, the work on these updated guidelines had been completed by HCPAC using a different methodology called GRADE to evaluate and make their recommendations. But of course, it took SHEA to get them published, and they were published in their journal for their members. With regard to vaccines and immunizations, the Advisory Committee on Immunization Practices, ACIP, and their recommendations have been widely accepted, I should say, and are the basis for insurance coverage for payment of vaccines, for example. Now, all members of that committee were fired, and the current committee is not made up of experts representing different areas like the previous committee. In the first meeting, and we could watch it on the internet, there was no method used for data review. That's a big void. So how about filling medical expertise with regard to vaccines and immunizations? The Northwest states have formed a vaccine alliance with their own recommendations, but these recommendations stem from the original CDC guidelines. The Northwest states involved in this are Oregon, Washington, California, and Hawaii. For the Northeast, another group has formed, the Northeastern States Health Alliance. This is made up of many more states. As you can see, Connecticut, Delaware, Maine, Maryland, Massachusetts, New Jersey and New York, Pennsylvania, Rhode Island, Vermont, and New York City, a much larger group. So what should we be looking for when we are researching for the most reliable current data? Well, the guidelines for immunization of healthcare personnel from 2011 is a good reference. Yes, it would appear dated, but it has full references provided for you. I think close to or over 300. So any part of their recommendations are footnoted. You can go to the end of the document, see the articles that were reviewed to support their recommendation, and you yourself can go to those references and check it out. The National Institutes of Health also just published a document that can help us. It is called How to Evaluate Trustworthiness in Science. So you may want to go to NIH and print out a copy of this document. It's only 2 pages, but it's really helpful. So HCPAC, which was dissolved in November of 2024, did pass some votes. And so I want to share those with you. One of them was healthcare workers and chickenpox vaccine. They voted that we wanted to be sure to offer vaccine to susceptible personnel, especially those who work with high-risk patients, those at risk for serious complications. They made it very clear that we do not need to perform titers before giving chickenpox vaccine. We can just administer the vaccine, no harm, no foul, especially if it's more cost-effective. We do not need to do post-vaccine titer testing following administration of varicella vaccine. With regard to measles, they stated a clearer definition for what constitutes exposure to measles. That in a healthcare setting, spending any amount of time while unprotected, meaning not wearing any type of mask, in a shared airspace with someone diagnosed with measles, at the same time you're in that space with them, or you're in that space up to 2 hours after that individual left that area. We know that measles virus can hang in the air for 2 hours after the infected person has left the area. They also once again stress the importance of cleaning prior to disinfection, that we have to remove any debris that would interfere with proper disinfection, and that we need no special cleaning solution following transport of a patient with measles. Any EPA registered disinfectant will suffice. And any disposable personal protective equipment and other patient care items for measles patients need to be disposed of in accordance with your local medical waste regulations. Recommend that you know what is in your state definition of what constitutes medical waste, because that is what OSHA follows. It's not the broad definition that OSHA gives. It's what your specific state regulations identify to be medical waste. So we can't stress enough the importance of checking references before accepting data. That's really critical in today's time. Yes, bad studies do get published, and that's why it is important to closely review information before just accepting it. No matter where it's from, always check it out first. Remember that one study does not yield scientific validity. You need at least 3 studies that are conducted the same way and yield the same result to have scientific validity. You can pretty much find one study that will say just about anything, but that's not valid. We have to do a little homework before we make decisions. Well, that brings us to the end of this segment of Let's Get It Straight. I hope the information will be helpful to you. I find it exciting that our associations are stepping up to fill in the gap, fill in the void. So now the onus is also on each of us to research information and not just blindly accept what is put forward, no matter where it's from. Do some homework. It's well worth it. Thank you for your time, and I hope you will join me again in the future for another segment of Let's Get It Straight. Take care.